Great. So thanks so much for coming, guys. We're going to go through COOP and some dementia stuff as well. So I'm not sure if you guys have done your COOP rotation or you're going to come onto it later in the year, but I'll just go through it anyway. Um, so what we're going to cover today is mostly about frailty, delirium, falls, dementia, that kind of thing, polypharmacy. Those like the big topics in COOP. We're not going to cover things that are kind of like fourth year recycled, like gout and pseudo gout, infection, osteoporosis, things like that. To be honest, you should remember enough from fourth year. It's nothing kind of additional on those topics. And then pressure sores, it's quite simple to go through in your own time. Just look at a picture of like the different grades of pressure sores, make sure you're familiar, and like the risk factors, things like that. It's not a big topic. And then DOLS or deprivation of liberty, Mental Capacity Act, that kind of thing. You go through a lot in the CBP in like the psych module, so we're not going to go through that in this tutorial. So I'm just going to talk about frailty. Also, if you want to say anything, please put in the chat or just unmute. So frailty is a concept where your body has a reduced physiological reserve. So small insults like infection, falls, electrolyte imbalances, things that you might be able to compensate for when you're not frail. When you're frail, they can really set you back, and it can cause quite severe illness, things that wouldn't normally cause severe illness. So that's kind of the model of frailty. And in the graph, you can see the idea is that you don't return to baseline. So after, say, an infection in an older frail person, they may not go back to their previous baseline, even after they've recovered. Frailty, basically, in COOP, they go on and on about it. So any tutorials, any teaching you have, that's like the main thing to get from the module. But at the same time, it's quite straightforward. So hopefully we go through it and you'll basically get it. There's two models. Phenotype model is a group of patient characteristics. The important ones are sarcopenia, so loss of muscle mass and muscle strength, reduced gait speed, sensation of fatigue, and reduced energy expenditure. And then the frailty index of deficit accumulation is basically the idea that you accumulate different problems and you never go back and recover from them. So that can be like different comorbidities, hearing loss, sight loss, that kind of thing. So hopefully that makes sense. As I said, it's pretty straightforward, and hopefully has been repeated quite a lot on the placement, or will be if we're going to do the placement. But we'll just do a quick question. So does anyone know, anyone want to shout out or type in the chat, what is the scoring system that is used to assess frailty? Someone put something in the chat. Yeah, perfect. Thanks so much. So the Rockwood score is used to assess frailty. This did come up. I feel like with scoring systems in med school, sometimes you learn them and you never see them again. But when I was on my COOP placement, they did actually use this pretty much on every patient. So it is worth definitely having an idea of. Just to go through what the other ones are, A is about sleep apnea, Waterloo is pressure ulcers, and you could definitely look that up. Like I said, because we're not going to cover pressure ulcers, you wouldn't need to know it, but just to have an idea. And then I'm sure you've heard of Glasgow, Batchford, and Charpie from Gastro. In terms of the clinical frailty scale, Rockwood scale, I guess, I don't know, I learned scoring systems like from the outside in. So 9 is terminally ill and 8 is very severe, completely dependent. So I would kind of remember those two like that. And then 1 is exceptionally fit. So to be honest, most of us probably are 2. 1 is people who are like, you know, very fit for their age. 2 is average. And then you kind of work in from there, you get slightly worse. Most people are like between 5 and 7, I guess. So that's kind of the one to differentiate. If you're seeing an older person, are they mildly frail, moderately frail, or severely frail? And that's determined by how much help they need with activities of daily living. So yeah, you can obviously just look this up in your own time. Moving on. There's a concept of a comprehensive geriatric assessment. So this is a bit like in psychiatry, they would like always say MDT. In Geri's just always say comprehensive geriatric assessment. Like if you get any OSCE with an older person as part of the management, just say comprehensive geriatric assessment. It basically involves, and I don't think that you'll be asked to kind of do this or know this in detail, but it's just about knowing what it entails and how you would refer someone for it, what kind of things would be required. So it's a medical assessment from a doctor, which includes a medication review, and then also a psychological assessment, functional assessment. So that would be things like occupational therapy, social worker, and thinking about end of life care planning and things like that, and also liaising with like relatives who might be able to give a collateral history. So like a really good thing to be aware of, comprehensive geriatric assessment. Um, these tests that can be used to assess frailty. Like I said, I don't think you'd be asked to do any of these, but just an idea of what they entail. So as I said before, in the phenotype model of frailty, gait speed is one of the features. So you can assess that by seeing how long it takes them to walk 4 meters. And then other tests like the get up and go test, how long it takes them to get up from a chair, walk and turn around. So if you wanted to assess if someone was frail in an OSCE, you thought it was relevant, you could just be like, have you noticed that you're a bit slower at getting up and walking than you used to be, or something like that. So just having an idea of these helps you to like think about things like that. So yeah, elements. You basically, as I said, I'm not going to go into loads of detail about this because I don't think you'll be asked to do it. But an idea of it is to have an awareness of the person's medical problems, know how they're being managed, how they're severe, and importantly, always like what effects they have on their daily life. So if you're taking a really good social history, if someone tells you that they've got COPD, you'd be asking them like, how far can you walk? Do you live in a flat with stairs? Can you walk upstairs? Does it affect you getting around in day-to-day life, etc.? Like I'm sure you covered that in fourth year, but in any sort of geriatric related auscultation, they really want you to ask those questions in like a good amount of detail about their functional status. So that's important. And then, yeah, just be aware of like mentioning pressure areas and aligning standing blood pressure is important as well. And always just, yeah, say that you do a CTA, sorry. Medication, think about are they able to take the medication? Are they confused? If so, they're probably not going to be able to manage like lots of different packets with different instructions. So do they have a Dosset box, that kind of thing? Do they have family that help, nurses? And then if you're asking someone about medication, you can ask them whether they think it's working, or you can assess whether it's working. So like blood pressure, take their blood pressure. You can ask them if they're getting any side effects from it, and also ask them, do they understand why they're taking the medication? Do they have any concerns? So that kind of thing. Next, psychological assessment. So things like a depression screening score, or a mental state like cognition screening score are quite good for this section. Then a functional assessment, like I said. So these are kind of the things they talk about, like the geriatric giants. So mobility, balance, so 4 I's, but immobility, instability, incontinence, and intellectual decline. So memory problems, incontinence, balance problems, and mobility problems. So these are things you really want to focus your social history around. So ask them about those things. How do they get around? Do they struggle with balance? And then, as I said, it plays into the frailty score, but any ADLs, like what can they manage with? And then in terms of care of the elderly, I noticed on my placement that they asked a lot about alcohol, because I think if you have alcohol withdrawal and you're older, it's can be more severe in terms of if you're already at risks of falls and then you are using a lot of alcohol, that is obviously a problem. Or if you are drinking and then stop drinking, that's a problem for falls and more at risk of things like subarachnoid hemorrhage, stuff like that. Not subarachnoid hemorrhage, sorry. You know what I mean, subdural hemorrhage. So that's like a thing to be aware of. In terms of social assessment, ask about who helps them, family, carers, things like that. With carers, yeah, I should have said this, but they'll talk about like package of care. So that means, do they come 3 times a day? Do they come 4 times a day? What do they help with? So ask them, if they say, oh, carers, ask them what the carers actually do and how often they come. And then planning for the future, which is, end of life discussions, all that kind of thing, and DNA CPR decisions. So that's important. And then here is like a form that would be an example of how you go about it. So I think in real life, it's a bit more simple because you just follow the form. And I think that all you really need is an awareness of what different things happen. So I hope that was all fairly straightforward. If anyone has any questions, let me know. Otherwise, I'll move on to delirium, which is the other thing that was really talked about a lot in COOP placement. So delirium is an acute confusional state, so it's different from dementia because it's an acute process, and it's different from dementia because it involves an altered level of alertness or consciousness. So it means that the person is either hypoactive, so lethargic, difficult to rouse, like they may be sleepy and difficult to wake up, or they can be hyperactive, which is like they have almost like an increased level of consciousness. So things like hallucinations and agitation. So that's the key difference. Obviously, with dementia, you've got memory problems, you've got confusion, got some of the same problems, but they have a change in their conscious level. And also, inattention is a key feature. So if we look at the 4AT score, which is used to assess delirium, you basically get points for an altered level of conscious level is the first question. And if you get 4 for that, if it's abnormal, you get 4 for that, which is the like threshold for considering that someone might have delirium. And then there's a quick assessment of like their current confusion, orientation to time, place, person. And then inattention is tested by listing the months working backwards from December. And then it should have an acute and fluctuating course. So it should be present in the last couple of weeks and not kind of a long-standing problem. So we'll do a quick question. I'm going to start a poll. If it doesn't work, then I guess we can just think about it. If anyone wants to say as well, or put in the chat. Actually, why don't you just put in the chat, because I don't know if the poll's going to work. It's probably simpler. There's not that many people on the meeting, so hopefully that'll be fine. So yeah, an 80-year-old man is in hospital following an NSEMI. He's treated with a SEN and is recovering well. He's become more confused and disorientated. His current medications are listed below. Which medications are most likely to cause the confusion? Anyone put in the chat? Great. Someone's put D. Yep, exactly. So essentially, opioids and benzodiazepines are 2 key medications when thinking about confusion. So generally, in terms of a medication review, if you get asked to do a medication review, or just thinking about like what, if you have an idea in your head, what medications are not always a good idea for old people. So like opioids, benzodiazepines, Z drugs, you're always thinking like confusion, risk of falls at night. Other ones, think more carefully about anticoagulation because of risk of falls. Think more carefully about NSAIDs because of risk of bleeding. Think more carefully about antihypertensives because of risk of postural hypotension. So just have an idea in your head of drugs that are more likely to be dangerous in old people. And these drugs, opioids and benzodiazepines, definitely ones that fit into that category. This is linked to a kind of wider concept about causes of delirium. So the causes of delirium are pain, infection, constipation, and also urinary retention, dehydration, and also electrolyte imbalance, and then loads of different medications. So like I said, sedating medications, diuretics, alcohol, steroids, and also metabolic abnormalities, and then environment. So things like sleep-wake cycle in hospital is really poor because it's basically fluorescent lighting 24/7. If you have already got an existing level of dementia and then you move to a new environment, it's very difficult for your brain to like figure that out. So even a change in environment can precipitate delirium. In terms of investigation, take a good history and address these things. Assess any evidence of these things, and then move on to bloods, which is just the basic things, but especially UNEs, glucose, thyroid function, B12 folate, potentially. Urine, don't do a urine dip in anyone over 65. Ask them about symptoms, and if they have symptoms, then send off a culture. If someone has no symptoms but they're presenting with delirium, it's worth sending it off because delirium could be the presenting symptom. So yeah, send off a culture, but don't do a dip. ECG and chest X-ray, and then refer to memory clinic. If someone has new onset delirium that's like sudden and there's no real explained cause, then MRI brain is definitely relevant, because they could have had anything. They could have had a bleed, they could have a tumor. So you definitely want to get that if there's not an obvious cause. Yeah. So in terms of management, you can do conservative, always, yeah, I should have said this with your investigations, but always present them systematically. So observations, bedside tests like urine dip, ECG, invasive, so bloods, and then imaging is how I present mine, but as long as you have a framework and just present them systematically. In terms of management, I always say conservative, medical, and then surgical. So conservative management would be move them to a well-lit environment, try and address the environment problems with like light in the daytime, make it dark at night. See if you can make the environment more familiar, like encourage them to have relatives visiting, things like that. Get them a clock, you know, those dementia clocks that say like the day and month, stuff like that. And then again, for agitation, you only treat agitation with medication if they're putting themselves or other people at risk. So if the patient's just agitated and they're difficult for the ward staff to deal with, it's not a reason to give them sedation. They have to be like persistently putting themselves at risk or other people at risk, and conservative management hasn't worked. If that is the case, you can give them IM, lorazepam, or haloperidol. Haloperidol, obviously dopamine, don't give it to people with Parkinson's disease. If you give someone IM sedation, they need to be on like OBS every 10 minutes. Like they basically need like one-to-one nursing during that time for an hour or so, because obviously you're giving someone sedating medication, so it can have side effects. Yeah, that's pretty much it. I don't know if there's any questions about that, or I'll move on to falls.
I have a quick question.
Yeah, of course.
Why are urine dips less reliable in over 65?
I'm not sure why it is the case, but all I know is that they're quite likely to be positive, and it's like asymptomatic positive dip. It doesn't really affect the person, but they have a positive dip. I'm not sure why they're positive, but that's just the case. Yeah, it's kind of like if someone's catheterized and they have a positive dip, you don't worry too much about it. Kind of same with older people. So yeah, it's based on symptoms, and if they have symptoms, send a culture, basically.
Okay, thank you.
I hope that makes sense. Great. So move on to falls. Yeah, so think about reasons for falls. Obviously, visual impairment, trip hazards, things like that. If someone's got poor vision, they get up at night to use the loo and they trip over things. Polypharmacy, so especially like postural hypotension. If someone's on multiple antihypertensives, then that risk of that. Obviously, cardiac causes for falls, just because someone's older, they can still have any other causes, like especially aortic stenosis in older people, but also like arrhythmias, bradycardia, things like that. If they've had a previous MI, they might have like AVN, block, and then ventricular escape rhythm, like all that kind of thing. So bear those in mind, always get an ECG. And then strokes and peripheral neuropathy or impaired proprioception are causes of falls, like lumbar-spinal stenosis. Incontinence is important, because if you're, like I said, getting up lots of times during the night to pee, then getting up in the night is a risk for falls. So always ask about incontinence and UTI symptoms. Hypoglycemia, if they're on any oral anti hypoglycemics like sulfonylureas or whatever, you need to ask about that. And then pain and arthritis, things like that, and also dizziness, vertigo. So I'm sure you learned how to do a falls history in year 4. It's exactly the same. Ask about before, ask about during, ask about after. And I guess the only real difference than the falls history you learned in year 4 was just to make sure that you do the social history really well. So all the things I talked about before about functional assessment, like do you have walking aids? Do you struggle with walking? Do you have any difficulty with hearing? How independent are you with your ADLs? Do you have anyone that helps you? Like all that, just go into all that really well. Do you drink alcohol? Like do a really good social history on top of just the general falls history. And then investigations and management. Obviously, if the person has just fallen or they're acutely kind of presenting, then the answer is always A to E. So that'll be the first thing. Then lying standing BP is super important, as I said, because of the polypharmacy, being on lots of antihypertensives causes postural drop, which causes falls. Blood glucose always, and then do a general set of bloods, look for any kind of inflammatory markers, suggestion of infection. Always do an ECG and consider an echo if you're thinking about aortic stenosis. And then imaging, definitely get a chest x-ray again, because it will look for like if there's an underlying pneumonia that's made them delirious or whatever, depending on the presentation, but it's not a bad idea. CG head if they hit their head, and obviously hip x-ray if they hit their head, or if they landed or they've got any pain in their hip. And then in terms of management, treat the cause. Strength and balance training, I think, is the most evidence-based intervention for falls. It's like a group class where they go and do like physio, I guess, in a group. So that's important. Assess osteoporosis risk. If they're falling regularly, then they'd be at risk for fragility fractures potentially. So think about that. Occupational therapy, vision assessment, and medication review. So again, the answer is just comprehensive geriatric assessment and MDT. So just say that you're going to figure out the cause and do the medication review. You're going to refer them to physio for strength and balance training, OT for home hazard training assessment, and then think about things like optician and also like social worker, can see what kind of home adaptations they can have, stuff like that. Okay, so we've got another SBA if you guys want to put in the chat. A 90-year-old female comes to GB complaining of worsening frequency of falls. Her echo and ECG is normal, but she's persistently orthostatic with blood pressure drops of 30 millimeters from lying standing. She's not on any diuretics or antihypertensive medication. She's euvolemic and there is no clear etiology. Which of the medications can be used to raise her blood pressure? Yeah, exactly. So she's got persistent orthostatic hypotension, sorry, and we don't really have a cause. So fludrocortisone, obviously mineralocorticoid, basically encourages your kidneys to hold on to salt and water, which increases your blood pressure. There's a few things in the history. So you've excluded any arrhythmias and aortic stenosis, which would be the first thing to do. She's not on any diuretics or antihypertensive medication. If she was, then reducing or stopping that would be the first step before starting something like this. And again, she's euvolemic, you'd want to check that. And there's no clear etiology, then fludrocortisone is the first line, and then you can use midodrine, I don't know how to pronounce that, second line. I've not seen people on this loads. I think mostly people with Parkinson's who've got secondary postural hypotension. I've seen them on medication, but otherwise not really. Usually it's reducing the drugs, like reducing the polypharmacy that they're already on, to help with this. So yeah, definition of postural hypotension is a drop in systolic blood pressure of more than 20 or diastolic of more than 10 within 3 minutes of standing. So that's important. How you actually do. One is they sit down, they have it done, they stand up for 1 minute and then have it done. They stand up for 3 minutes and have it done. They stand up for 5 minutes and repeat. So that's how to do a postural hypotension, like blood pressure properly, not just like stand up and then 10 seconds later do the reading. So yeah, because it can continue to fall over like the first minute or so. So that's why it says within 3 minutes of standing. In terms of causes, it can be idiopathic. Obviously, if you're hypovolemic, it's going to be, you're more likely to have postural hypotension. Autonomic dysfunction due to diabetes or Parkinson's, and then various drugs. So as I said, always think about medication, think about compression stockings, food and salt intake, things like that. And if required, that's the pharmacology, the pharmacological options. Okay, I hope that's fairly self-explanatory. I think most relevant is probably the medication side effect and recognizing where you need to reduce or stop medications that cause postural hypotension. Okay, so we have another SBA, if you guys want to put something in the chat. An 87-year-old guy is admitted to the emergency department following a sudden collapse during which he lost consciousness. It was not witnessed, but his wife found him lying on the bathroom floor and subsequently called the ambulance. His past medical history includes atrial fibrillation and he takes warfarin. Bloods taken in A&E show that his INR is 4, and a CT head shows the following. What is the single best management for his anticoagulation? If anyone wants to put in the chat the answer and also what they think the CT head shows. If anyone wants to volunteer that. Anyone want to answer? Or if anyone doesn't know, they can put, oh, E. Yeah, so that's not quite right for this one, but that is something, yeah, we'll go through. I did not know this in 5th year, but we'll go through what you do to reverse warfarin. So you definitely do want to stop the warfarin, but in terms of fresh frozen plasma, that's not the first line. Someone's put star sign. Yes, exactly. So I don't know, can you guys see my mouse? Probably not. Yes, subarachnoid, exactly. So if you look at the CT, it's if you look at the middle, like the dot in the middle, it's white around there, and then white in the gap between the lobes at the front, if that makes sense. It's annoying you can't see my mouse. I'm wondering if I can get like a pointer. Let's see. Let's see. Maybe we can see this. Oh yeah, so this is blood, and this is blood, and blood, and blood here. So there's white in the gaps between that shouldn't be there in the ventricles, and yeah. Oh, and you can see my mouse. Okay, great. But yeah, you can see the blue line as well. So this is like the star sign of subarachnoid hemorrhage. So there's blood in the ventricles that should be black. So that's what is going on there. So we know that this person is on warfarin, they're anticoagulated, and they've had a major bleed. So we want to reverse the warfarin. So Michael correctly said stop warfarin, obviously, but we want to figure out what to do. So I'm going to go through the guidelines with you. So basically, if someone has had major bleeding, regardless of their INR, so major bleeding would be, oh, this squiggle's going to be there forever. Major bleeding is any kind of intracranial bleeding is obviously major bleeding, and then any bleeding that's causing hemodynamic instability, stop warfarin, give intravenous vitamin K 5 milligrams, and then we actually give prothrombin complex concentrate. So FFP is an alternative if PCC is not available, but the first line would be PCC. This is a screenshot from PassMed, so if you want to go look it up on PassMed yourself, then you can do that. But just to quickly go through it. And then if somebody had minor bleedings, that would be something like bleeding from like a nosebleed that wasn't causing hemodynamic instability. Again, like minor PR bleeding that wasn't causing hemodynamic instability. If their INR is more than 8, then you're going to give IV vitamin K, stop warfarin, and recheck. If their INR is 5 to 8, again, stop warfarin, give the vitamin K, and recheck. So basically, if they've got minor bleeding and their INR is more than 5, you stop the warfarin, you give IV vitamin K, and you check in 24 hours. So these two different ones are the same. Like, forget about the over 8. If the INR is over 5 and they have minor bleeding, stop warfarin, give IV vitamin K, check in 24 hours, and then restart when the INRs come down. If the INR is over 8 and they have no bleeding, you stop warfarin, give oral vitamin K, and check in 24 hours. And then if they have no bleeding and their INR is high, you just, it's high, but it's below 8, then you just hold warfarin. So basically, the questions are, do they have major bleeding? If so, give IV vitamin K and PCC. Do they have minor bleeding? If so, stop warfarin and give IV vitamin K. Is their INR over, if they're not bleeding, is their INR over 8? If yes, give vitamin K, stop warfarin. If they're not bleeding and their INR is over 5, but not over 8, then you just hold the warfarin. You don't need to give any vitamin K. Hope that makes sense. But again, I think it's probably easier if you just go on PassMed and look at this table in your own time and memorize it however it makes sense to you. Where am I? Okay. Okay, so you have another SBA. So a 76-year-old lady has had a fall after tripping on her carpet and she's fractured her hip. She was found 6 hours later by her neighbor who usually comes to deliver groceries. On arrival to A&E, she was clinically dehydrated, hypotensive, and tachycardic. And she has an AKI secondary to rhabdo. What electrolyte abnormalities are seen in rhabdo? And these are options. Someone's put C. Yeah, exactly. The answer is C. Well done. So rhabdomyolysis, it causes muscle breakdown. So the CK, which is a marker of muscle breakdown, is elevated. So you can already exclude A and D. And then potassium is inside cells. So you've got breakdown of cells. So potassium leaks out of cells. So you're going to have an elevated CK and an elevated potassium, and then also hypocalcemia. So that's really the only thing to like remember is that it's hypocalcemia. The other two are kind of obvious from muscle breakdown, at least, yeah, if you remember it like that. Yes, so what is rhabdo? It's basically an older person who has a fall, has a long lie. Their muscle breaks down, and then they get an AKI from the released products damaging kidneys. So it's a AKI with a really high CK, like over in the thousands. And then the hypocalcemia comes from the myoglobin binding calcium. So that's the only bit that isn't particularly intuitive. It causes hypocalcemia. And then phosphorus and potassium are inside cells. So when cells burst, they get released. And then also cause the metabolic acidosis. It can also be caused by prolonged seizure and crush injury and statins, as well as collapse with long lie. So if someone with statins develops muscle pain, you always want to do a CK. And if the CK is very elevated, like in the thousands, then you want to stop the statin. Statins interact with clarithromycin. That's important. So if somebody's on statin and they need clary, then you would usually just stop the statin while they're on it. It's because they're both P450 and clary is a P450 inhibitor, so it increases the amount of statin that is available, basically. Yes, other than rhabdo, I think that's basically what I basically said everything about that. Okay, so that's literally the end. I'd be really grateful if you guys could fill out this. I'll just give you like 1 minute to put any questions in the chat or unmute if anyone wants to say any questions. Otherwise, I'll stop sharing and Jazz, you can start sharing.
Yeah, let me just grab that. I think my screen has been shared. Yeah. Yeah, okay, I'm just going to move on for like time's sake. But I'm going to cover the rest of the topics, starting off with dementia. There's just 4 simple SBAs. So we have the first one. We have an 81-year-old patient seen as GP. She reports that he seems increasingly confused. His memory has been poor for the last year and a half. And around 6 months ago, he started to have difficulty finding words. And for the last couple of weeks, he's had problem with decision making. He takes those medications listed above. And what is the most likely diagnosis? So again, if you can just pop in your answers into the chat. A. Good attempt, Claudia. So the answer is E. The reason why, and we'll go through kind of like what are your kind of spot or trigger words that come up in like SBAs or, for example, in OSCEs as well. So the answer in this case is vascular dementia, and the key thing that they've mentioned in this question is like the different time aspects. So they said this has been going on for 18 months, then 16 months, and then now for the last couple of weeks. And then what is typically seen in a vascular dementia is a stepwise decline. So if you kind of view it as like stairs, it's kind of like going down the stairs, it's getting worse and worse over time. But good attempt. It does kind of seem like Alzheimer's, but we'll do another SBA that kind of shows how that's a little bit different to that. So with the second one, kind of the same kind of clinical scenario, we have this patient seeing the GP, but instead of that going on, his memory's been getting worse for a number of years, and last week he left the hob on and started noticing that he's getting things wrong, got lost driving home. So in this case, what would be the most likely diagnosis here? Yeah, perfect. Well done. A. So kind of as mentioned just previously, this is more of like a slow gradual decline, and that's how you really differentiate between the two. So with Alzheimer's disease, it is the most common, so if you ever get stuck, it's great to just pop that in anyways, but it is the most common one, but it's a kind of slow gradual decline in different aspects of the brain and cognition, and it gets worse over time and it's progressive. And the key difference with vascular is that you kind of have like your stepwise decline, and they're at that kind of baseline for like a number of months, then it gets worse and it gets worse over time. And in addition to that, they have a risk factor of vascular features. So they might have kind of coronary heart disease or some sort of peripheral artery disease, or just kind of like poor lifestyle factors, which make them higher risk for vascular dementia as well as previous strokes as well. This third SBA, so again, we have the same patient over here, but what's going on with him is that he hasn't been himself for the last 12 months, and he's been finding it difficult to make decision. And last week he got very upset and feels and sees men dressed in black walking around their garden, and his wife says that he can't see, they couldn't see anyone. So this is your classic seeing things that are not there. And we've got C, perfect. Yeah, this is our kind of Lewy body dementia. I think the give go like which gives it away is just like kind of seeing small animals or small things that, and hallucinations are not clearly there, which gives it away being Lewy body dementia. Okay, and the last SBA, I guess this one can be kind of easy to tell. It's the only one left, but essentially we have a patient that's becoming more aggressive, increase in like shopping habits, and yeah, perfect. It is frontotemporal dementia, which is due to kind of personality change. So brilliant. So this is just an overview of kind of like the types of dementias that you'll get tested most on. There are your other ones, such as your pseudodementia, which we'll touch upon in a second, but kind of know your Alzheimer's disease by heart. I'm going to just have this on the screen, but things that to just bear in mind on what they like to test on and how they like to pop this into an OSCE. In SBAs, kind of know like your key buzzwords, stepwise decline, vascular path, like background and risk factors. Know what this looks like on like a histopathology slide. That's something key that they like to test upon as well. I think that's pretty much it in terms of what's high yield. I'll get to the OSCEs part in a second, but these dementia mimics are very, very common, especially the pseudodementia. They like to pop this in questions. So the way that they like to tend to put this in SBAs is that they have a mocker or some sort of like mental assessment test, and that would come out really high. So they would score like 28 out of 30, for example, and that is a test that normally tests for like Alzheimer's disease, but because they have like what looks like dementia but a very high like mocker kind of results, it points towards more pseudodementia, and that is very common in the elderly as well. Know your normal pressure, hydrocephalus as well, your weird and wobbly, that tends to come on quite a lot as well. And these other ones, again, these are just kind of rote learning, but they like to test you on those 4 in particular. In terms of how we investigate and manage, this is very much more of like explaining to like a family member in like a OSCE or CPSA situation. So firstly, explaining the term in layman's term is really, really important. So explain what is dementia, saying it's very common, but it's not a normal sign of aging, making that very, very explicit, because that tends to be in mark schemes. How we like to investigate is to rule out any kind of organic causes by these tests over here. And what we like to do is refer them to the memory clinic if there's any signs of like changes. For example, if a person is being confused, we always like to refer them to memory clinic, and that's something that's really key to highlight, and offer them a CT head if eligible as well. These are your cognitive assessment tests. I think the ones that I would learn in particular for an OSCE would be the 480, just because you can quickly do that and integrate it within a station. And then in terms of how we manage dementia, so more specifically with Alzheimer's disease, we like to do the Dom-Penzl, which is our first line, and this is used for mild type dementia. And when it gets more severe, then we kind of step up and we use memantine, for example. And again, this is not kind of first line for Lewy body dementia. It's actually not advised at all. In terms of just kind of focusing on like what could happen in the OSCEs, I think it's really important to have like your go-to management for these wider cases in COOP. So dementia is a very common one to come up, and it's really important that you mention other kind of teams that are involved in such a long-term condition, such as getting your district nurses. So that's a key buzzword to kind of drop in as well. Always talk about OT, PT, your occupational therapist and your physiotherapists are really important, like people to just involve and just say in your management plan, because a key thing between 4th and 5th years is describing your management plan to the patients, because you're in the role of a foundation year doctor, not a medical student anymore. So it's really important that you talk about these other teams that are going to be involved in the care. And I would always mention package of care, QDS, like that's just a key one, just to show your examiners you know what you're talking about. Question, which cognitive assessment would you recommend to learn for the OSCEs? Sorry, it was the 480, just because you can just do it within your integrated stations. So if you have like a confused patient, if you're assessing a patient, for example, and there's like acute confusion, even if it's a history, for example, you can do a quick 480, and I think it's made out of 4 parts of location, age, date of birth, and the year the patient, what current year it is. And if you do a quick screen, and if they can't answer like 2 or 3 of those, then you know that they have like delirium and not dementia for for that case. Does that make sense? Yeah, perfect, cool. Okay, so moving on to urinary incontinence. So again, this is a very common topic. You're taught like the 5 geriatric giants, and this is one of them. Your main 2 is urge and stress, which we'll go into in a second, but also it's important to learn these 2 as well. So voiding problems are just for anything that can obstruct the flow of urine, and that could be, for example, obstetric, as like BPH, for example, having a neurogenic bladder, and just having like, for example, being constipated as well can cause incontinence. And then functional incontinence is external factors that can prevent someone from actually, for example, using the bathroom, that can lead to incontinence. Why is incontinence a big thing? It's just very commonly seen in the elderly. So it's something that if you realize you're taking a history and you're asking, you're talking about something else with an elderly patient and you know it's COOP, I like to always scan like the other 5 geriatric giants as well, including incontinence, because that's something that can be easily treated as well. And it just shows kind of lateral thinking. But focusing on the 2 that you'll commonly see is stress and urge incontinence. So with stress incontinence, this is due to kind of a weak pelvic floor. If, for example, it's a female patient and they've had many natural births, for example, vaginal births, that can lead to stress incontinence due to a weaker pelvic floor. Whereas urge incontinence is about a kind of overactive bladder, and the 2 are very distinct, and they have it as their own kind of like symptoms. So stress, for example, like coughing, and coughing can cause leaks, for example, and what's urged is like the frequency, the urgency in going to the bathroom frequently at night. In terms of how to kind of approach this, again, just more focusing on like the OSCE kind of starts side, always kind of say your lifestyle managements, your medical managements, and then your surgical managements. So your lifestyle and management includes losing weight, if appropriate, decrease smoking, look at the medications, decrease alcohol and caffeine intake, as well as keeping a bladder diary for at least 3 days, as well as if the patient clearly has stress incontinence, giving them pelvic floor exercises, TDS, so 3 times daily for 8 contractions, TDS for over 3 weeks. And if that fails and that you need to review them, then think about stepping it up into medical surgical management. So for stress, it's about using this retropubic mid-urethral tape. And if clearly they don't have a good performance status or they're not appropriate for surgery or they decline surgery, we think about duloxetine through SNRIs that can help with stress incontinence. If it's clearly an urge incontinence picture, then we're thinking about bladder retoning. That's something that I think urologists push to do as much as possible before stepping up on these medications, just because they have a very high anticholinergic burden, and especially because we're talking within the realms of COOP, you don't want to put them on too many like tricyclics and anticholinergic medications just because of the side effect profile. And what we'll talk about in a second with polypharmacy, these are a lot of medications you would stop. And also they predispose you to falls as well, which is definitely what we don't want to be doing. But yeah, and if it's, for example, an overflow, if there's constipation, treating the constipation. So again, thinking about, do they need to be seen by a nutritionist? How can we increase kind of like them having meals in the day? So often, I think I used to say meals, the Meals on a Wheel scheme that the government did, just to drop that in, thinking about the holistic care when thinking about COOP and Jerry's patients. So stroke and head injury, a very big topic all throughout your clinical years. I'm not going to go too much into like the actual backup of like what a stroke is and the types of stroke. Just know your differences, know your timelines, like 4 hours, your contraindication, because those are SBA-able. In terms of managing it and how you kind of go about it in like an OSCE situation with an elderly patient, know how to do an NG tube. I think you learn it in 4th year, you'll need it for final year, you will need it for 5th year, just in case if that does come up. So how to consent for an NG tube, know how the procedure works. I don't think you'll actually will ever need to put one in like an OSCE. I really doubt that clinical skill will come up, but just in case if it does, do know how to put it in, but definitely know how to consent for it. And in terms of like how to approach it, if it does come up, think about again the other teams involved if a stroke happens. So if a patient, an elderly person, are often the cohort of people that have stroke. If they have a stroke, think about again, okay, they need to be seen by a SALT team. So that's something, a key team to be seen by and mention. So speech and language therapists always mention that with stroke. You also want to talk about OT and PT, because often what happens post-stroke, you have paralysis or loss of function of muscles. So think about strength and balancing training with OT PT team. And again, if they need a package of care, because obviously if they are frail and their baseline have kind of reduced now, you want to see if they can put in any kind of equipment at home, for example, to help with their daily function and their ADLs. And that's the key thing for stroke. I'm pretty sure we did get a question on this in our finals, so do learn this. It's again, the difference between total and partial is just essentially how many of these factors are presented in the patient. Lacuna, your rare ones, either pure sensory, pure motor, you'll kind of clearly tell from the stem if it's a lacuna stroke, and your posterior one is where you have your kind of your weird name strokes, as well as anything to do with the eyes as well. But again, like they're not going to ask this in an OSCE and SBA, it will just kind of ask you which kind of stroke is present. Okay, cool. So we've got another SBA. We have a 78-year-old woman who presented to A&E. The patient appears drowsy and confused. Her sister tells you that she has deteriorated over the last 72 hours following a fall. The patient has a history of OA, hypertension, and AF, and she takes amlodipine, cocodamol, atorvastatin, and rivaroxaban. So what is the most likely diagnosis in this case? Brilliant. Yeah, perfect. Yeah, it's subdural. And the key giveaway is that she is she's elderly and she's on a blood thinner, so it predisposes it predisposes you to have a subdural over an extradural as well. But yeah, no, your common risk factor for subdural is elderly, being on blood thinners, and also alcoholics as well. And then your extradurals, like your head injuries, for example. In terms of what key things to kind of mention is that you will get x-rays and CT heads. They will be of poor quality, so do look at them really quite carefully in your exams. And it's all about kind of like spot diagnosis, like that's clearly a crescent shape over here. This will be like 10 times more blurry in like your SBA, but clearly, if you can clearly see that, go for your subdural. So we see subdurals in this age category just because as a patient does get older, the brain does get atrophies and gets smaller, and if there is kind of like light injury or a fall, it can cause a catastrophic bleed. And this is specifically for the bridging veins, another key thing to kind of mention. And with a no. Okay, so subdural, you'll see a crescent. I don't know why this says lens, but with an extradural, you'll see a classic like lens or concave lens shape, or like egg-like picture shape. And with your extradurals, that's your high kind of injury towards your temples of your head. With kind of like managing a subdural, it depends on the patient and the performance status. Are they suitable for surgery, or can we just kind of reverse their any anticoagulation that they're on? Obviously, it's a bleed to a head, so this is a major bleed, so you have to escalate as needed. And in terms of like reversing the bleed, as what my peer just said previously about how to reverse like warfarin, or know your reversal agents for your DOACs, because they're commonly used now instead of like warfarin. We're kind of phasing them out. So perfect. And know your CT head guidelines. Know both adults and peds for 5th year, because that does they do like to ask questions about that. They won't specifically say that they're asking questions about the CT head guideline, but it's important to know them. Know when to take a CT head in 1 hour, and then when for 8 hours. My best tip is just to land like 1 hour, and if it doesn't fit clearly the 1 hour category, it will most likely be 8 hours, unless the patient's completely fine and they're very young. Then you can just give head injury advice and you can discharge them. But do know, look at GCS, know how to calculate a GCS. That's a big thing that we learned in like 6th years, like knowing like, it's all good to ask the nurse in your station to like give us the GCS, but they might actually turn around and say like, can you please calculate it? So do like know how to calculate GCS and how to calculate the score out of 15. And that could be seen in the STEM, or that can be seen with your patient that you're seeing in your OSCE. And then any of these signs shown below, if that's present, it warrants a CT head within an hour. And if it isn't, it's most likely to be 8 hours unless the patient's completely fine and they're very young. Then you will discharge them from the ED department with just head injury advice. Brill. Okay, and then I think this is our last topic on polypharmacy. So you guys will end up writing a whole essay about this, I think, during like one of your modules. But polypharmacy is where a patient's on 4 or more drugs, and that is very, very common for patients to be on more than 4 drugs at a time. And that's why they've invented the term hyperpolypharmacy, with more than 10 drugs at a time, because that is very, very common. Now, being on many drugs can be beneficial for different conditions, but being on them together can be quite detrimental and can predispose them to other conditions, such as a fall, for example, or higher risks of bleeding. So what we can do is use the stop-start tool. You don't need to kind of know exactly which ones to stop, which ones to kind of start, like from the little guidelines and tools above, but just know like your anticholinergics in like an elderly is something that you definitely want to stop if they are having falls, and know when to kind of stop, like your classic, if they're on atorvastatin and they're 90 years old or 80 years old and they have, for example, a very severe kind of past medical history, or they're chronically unwell, it would be appropriate to stop a statin, for example. It would be appropriate to stop like certain diabetic medications as well, if their kind of prognosis isn't that well. In terms of how to kind of bring this into an OSCE, I think I used to just say like we would use a stop-start tool to make sure your medication's optimized. But just know that this is a tool that we can use, but you don't need to commit to like which ones exactly. Just one thing I just got my head around is when we talk about like tricyclic antidepressant or anticholinergic medications, which ones are they exactly, to make sure you know how to kind of spot them out as well. Okay. And then we have this SBA. So we have a 73-year-old woman who's seen by her GP. She fell yesterday in her home, and though she's uninjured, is concerned that she may have a fall again in the future. She's fallen once previously in the last 6 months, and she has a history of polymyalgia rheumatica, osteoarthritis, AF, and has an MI 15 years ago. So of which medication below is most likely have contributed to her fall? So think about which drugs could potentially predispose someone being unsteady on their feet. Okay, I'll go through it. Codeine is coding's the correct answer in this question. Codeine, morphine, anything that has like that affects the opioid receptor is something that we want to not put a patient on for long term as well, especially elderly, such as benzodiazepines as well, just because of the sedative effect they have. It increases the risk of fall. So that's why that's the answer in that sense. We have this lovely mnemonic. We have BOSS, BAN. These are these drugs that can predispose someone or increase the likelihood of having a fall. So if you do have a situation where you're kind of reviewing a drug chart, for example, and you see a patient is having like multiple falls, see if there is an offending drug, such as one of these, that could be predisposing the patient to this fall. So your benzodiazepines, typically we don't like to prescribe them for more than 2 weeks, or just because firstly they can be addictive and they can increase the risk of falls. Your opiates, any TCAs, your sleeping tablets, your vasodilators, as mentioned with postural hypertension, your sedating antihistamines, and your neuroleptics, which aren't commonly used nowadays, but phenytoin and carbamazepine, again, these are just not nice drugs, especially for the elderly population. Our next SBA, we have a 73-year-old woman who's seen by the GP. She was diagnosed with Alzheimer's disease 3 months ago, and despite starting donzapil, her daughter feels that there's been a little bit of improvement. The GP reviews her medication, and which of the medication below is most likely to contribute to her confusion. Bro, yeah, perfectly, yeah. So that is correct, and that is because it's an anticholinergic, and that just has a kind of side effect profile that increases the risk of confusion being one of them. So this is kind of like a huge topic, and essentially when an elderly patient has taken an anticholinergic or many anticholinergics, that can increase the risk of confusion, predisposed to delirium as well. And the main drugs are the one listed in this chart, but the ones that you'll commonly see and be asked about is antipsychotics, sedating antihistamines, your TCAs, and incontinence drugs. So even though elderly people they do have a higher risk of having incontinence, and we do put them on these drugs, it does can predispose them having confusion and falls as well. So it's about balancing and fine-tuning what is correct for a patient. And these are our other drugs that have, again, with any drugs that we see, we look at the benefits and like the risk and see what outweighs which. But anticoagulants, so if a patient is falling quite frequently, and it's one of the criteria as well, we might not choose to anticoagulate them just because there's a risk of a major bleed, for example. NSAIDs, especially NSAIDs, can precipitate heart failure, and elderly patients may have heart failure and renal dysfunction, so we might want to avoid these, promote kind of paracetamol instead of NSAIDs, SSRIs, beta blockers, and also a lot of kind of antipsychotics as well, just can predispose elderly patients to VTEs and strokes as well. So those are kind of other drugs to mention. But that's it. That's the end of kind of like the key topics that we think are kind of high yield in COOP and Jerry's. Again, this is just the same QR for the feedback. But thank you so much for sticking around. If you have any questions, feel free to answer. We'll stay for like a couple of minutes or so about COOP or like just in fifth year exams in general. But otherwise, thank you. And I'll just keep it back on here. What did I mean by, what was the ND2 thing for stroke you mentioned? What was the ND2? What did I say about the ND2? Let me actually